Good morning and welcome back to Good Samaritan's Facebook Live. My name is Adam Thacker. I'm the Chief Operating Officer here at Good Samaritan. As you can see, I'm running solo today. Dr. Stine had medical attention that he had to tend to, so he's being a doctor today. So we'll give him some slack for that. Just start off with our report on the numbers and where we're at. The positivity rate, as you see online, 10.7% for Knox County for the all test, and then we are just under 30% for unique individual, which is the number that we talk about frequently. Now keep in mind we're coming out of a extended weekend, a holiday weekend. Hope everybody had a safe and happy Thanksgiving. We're able to celebrate in ways that were recommended to make sure that we're cognizant of potential transmission of COVID, but still able to see family, whether it be virtually or in a distance manner, and keep those numbers down. We will see additional reporting coming in today that will hit the state. So expect those numbers. While they're down a little bit from what we reported last week, we expect by the end of today that those will be increasing, because we continue to see pretty steady transmission across the communities. We have 347 active cases that are being followed. Really, we've been in that 350 to 400 range for a couple of weeks now, which is tied into the high positivity rate. From a county perspective, if you go on to the State Department of Health site and you see the color-coded state, from the blue to yellow to orange to red, Knox County sits at a orange county, a score of 2.5 on the scoring, and really all the counties around us sit at that same 2.5, with Sullivan County actually being red to the north of us. The reason that's important is because we have seen over the really since end of October, we've seen increase in cases and have moved from yellow to orange, and now still orange, but the number creeping up. And if the trend continues in the direction that we're seeing today, we expect in the next couple of weeks that Knox County will turn red. And so what that means is that with the state restrictions, we'll see additional state restrictions. Also, as part of the state program, one thing that's expected of orange counties is that there is a group of decision makers, elected officials, health officials, school officials, business officials that are meeting and talking about what do the cases look like, what can we do to decrease or curb transmission. So in moving to red, if that continues to be the trend, gatherings go from 50 down to 25. There's additional restrictions around social distancing in businesses and hours of operation and all of those types of impacts that will come into place. Nothing set in stone yet, but there is a group meeting weekly and talking about what that will need to look like as we move further into December and certainly into the Christmas season. Dr. Fauci was quoted as mentioning last week that we're really going to see a surge on top of a surge. So we're coming into Thanksgiving and then moving into Christmas. So as we see that time coming, obviously we go through this every week. Masking, we have the mask mandate in place, but making sure that we are adhering to that, social distancing wherever possible. Certainly we're moving into a weather season that outdoor is not as much of an option, but where that's a viable option, open air is certainly recommended. And then hand hygiene, cleaning surfaces, staying on top of all of that as we have more indoor activity. And then if you need to be tested, if you're having symptoms, have been identified as a close contact, that's really where we recommend testing. So testing, I'm asymptomatic, I'm curious, is not recommended for testing. And as we've seen increased transmission in the community, we're doing a lot more tests. And so that puts a lot of stress on our systems and any of the testing systems. So as we see that, our recommendation is if you're symptomatic, contact your provider, go to convenient care, get assessed by a provider. If you have been identified as a close contact, and are starting to exhibit symptoms, then testing certainly is appropriate, just not testing out of curiosity. Convenient care, our largest primary care sites at Medical Center of Vincennes both have testing sites, can be assessed by a provider and then deemed necessary for testing. We are performing more and more of the point of care rapid tests, so within 20 minutes there's a result, but that test is approved for ages 5 and up that are symptomatic, ideally have had symptoms for more than a couple of days, which increases the validity of the test. All testing, not just the rapid point of care test, but also the nasopharyngeal swab, which is the molecular test. All of the tests have a higher sensitivity when you've had symptoms for a couple of days. So that's important. That's the test protocols. And as we move into why testing is important, with testing, we also have new outpatient treatments. So we talked last week about bamlanivimab. That's an outpatient monoclonal antibody product that is actually produced here in Indiana by Eli Lilly. We're fortunate to have a pretty strong allocation of that product. We also received last week news that the Regeneron monoclonal antibody product was approved for FDA emergency use. That's the product made famous by President Trump when he received that treatment some months ago now. And so we have both of those, and we have an allocation, but they require that symptomatic positive COVID result to be eligible for that treatment. And then it's a small number of patients that are eligible for that. Usually are patients that are of high risk, our older population. We have a protocol by which that happens to identify those patients, but fortunate that Good Samaritan is receiving allocation for the monoclonal antibody treatment and able to provide that to a number of patients. Thus far, we have seen patients that have had that treatment have stayed out of the hospital, and that's the goal of the treatment, is to provide that antibody therapy, which helps to neutralize the COVID virus itself, and then keeps folks out of the hospital, which decreases burden on the inpatient side. As we're in this time of season, we see a busier inpatient census at Good Samaritan pre-COVID. When you add in now, we have this pandemic response and the surge that we're seeing in this latter part of the year certainly puts a lot of stress on our inpatient workforce from a critical care standpoint, from a general medical standpoint. We've seen an increased census, but are able to manage that on a day-by-day basis. Our team does an excellent job of really focusing in when they come to work and being the heroes that they've been recognized for since March. So that's good news on that front, that we have some options in the outpatient treatment area that can help to take pressure off of our inpatient. And then certainly as we look forward to what's coming down the road, outpatient treatment is a positive change in the COVID response. And then vaccine, a lot of publicity around the vaccine, more and more information coming out. Pfizer, as we mentioned last week, has submitted their emergency use authorization to the FDA. We learned through some additional publications that December 10th is actually the day the FDA will review that. And that's a very quick process. It's expected to be reviewed on the 10th and approved on the 10th, and then will be available for mass distribution on the 11th. Now there's some logistics that goes into place on that, so that doesn't mean on the 11th that we will start administering the vaccine, but it does mean absent any delays that the following week, the week of December 14th, sometime that week, we will start providing COVID vaccine to the healthcare workforce for Knox, Davies, and Pike. As mentioned in the past, Good Samaritans identified as the distribution site for those 3 counties, with the healthcare workforce being phase 1 that will get vaccinated. Always get the question, how many vaccines will you get? What does that look like? There are weekly calls with the state, and that's still being determined exactly what that will look like. But we do expect to get ongoing shipments and be able to vaccinate our healthcare workforce by the end of January is the goal. That by the end of January, that we have offered that to the healthcare workforce in those 3 counties, and then can move into the next phase, which the next phase will be that population that right now is really eligible for outpatient treatment. So it's our older at-risk population, over 65 or over 55 with health conditions, heart, lung conditions that may make them more susceptible to the COVID virus. All right, so with those updates, I think we are at a point to see what questions we have this morning. And Dr. Stine has joined us. He's done playing doctor and ready to jump in, so I'm going to slide my chair over.
Really looking over the course of the past few weeks or so, when we got our initial bamlanivimab in and have administered those initial doses, we've really seen good results out of that. And our primary use of that has been early in the disease process, and then in individuals, just like Adam was talking about, that are kind of our highest risk population, which is typically those over 65, those with comorbid conditions, so typically diabetes, COPD, emphysema, asthma, immunosuppressed conditions, things like that. And thus far, we've seen very good results out of that. And then kind of the most exciting thing is the delivery of the next Regeneron product, which is essentially a cocktail, if you will, of a couple different antibodies that they put together, and very similar results. And the other thing that's exciting, I was talking with Dr. Mahan about last night, is really very few side effects. As far as administration issues, it was essentially the same as placebo. So we've seen good safety associated with it. We've seen relatively quick turnaround time as far as the illness is concerned. And now that we're seeing more of those doses coming in, we're expanding the number of people and the types of patients that we're treating with it. So certainly the 2 highlights I would say over the past couple weeks have been the accuracy of our point of care testing has been better than what we expected. And then really the delivery on that monoclonal antibody, and then now the Regeneron product coming out this week is kind of the next highlight that we're seeing, that has been successful, and patients are seeing a benefit from it. And as you said, one of the biggest benefits from our standpoint organizationally is it helps people get better faster and keeps them out of the hospital, and helps us better allocate our resources for those that are sick and are hospitalized in the inpatient setting.
And I didn't mention, we often stick to what's the clinical response. Mm-hmm. But we've been very, I'll say, fortunate that these initial doses, the federal government has purchased the bamlanivimab and the Regeneron doses. They're being allocated out to states. So while there's an administration fee for the resources that are put into the hour-long infusion, the drug cost, which sometimes can be cost prohibitive, we know, the drug cost has been subsidized by the federal government. So there is no cost to that treatment that goes to the patients. There's just the administration fee that goes to insurance, and that's typically covered. So it's very little to no out-of-pocket cost.
Yeah. I've had lots of questions over the past week or two, now that we've been giving more of this, from colleagues and from people out in the community asking, what is this stuff and how does it work and is it safe and so forth. And so really the way to think about this is they have looked at patients who have had these illnesses, looked at what antibodies have been formed to those, figured out the formula as to how to grow those antibodies and synthesize those in the lab, and then they've studied lots of different versions of them. And then basically when they find out which versions seem to work the best, they distill those down and grow those cell lines for long periods of time and develop this product. And really the interesting thing about it is these products have been around for a long time, right, and have been used for a variety of other things, and now they've basically been applied to what we have now and what we're dealing with COVID-19. And so it's nothing mysterious and they just pulled this out of nowhere. This type of process has been around for a variety of disease processes, and in some of the issues that they had with epidemics overseas with similar type of viral illnesses, this is what they used. And so there's been quite a bit of experience already out in the real world in terms of how this has been used, how it's been applied, and then what the results have been. So it's not something mysterious that poof kind of came out of nowhere. This is technology that's been around, but basically they have managed to filter this down to what the best products are. And bamlanivimab was the first one to come out, and then Regeneron is a cocktail of 2, of which I can't pronounce either one of those yet either. We got to have a little bit more practice time on those, but it's essentially 2 monoclonal antibody strains that they have put together and said these 2 don't compete with each other, these 2 are active against the illness, and essentially that's what the second product's going to be.
Right. Okay. Questions?
Okay. One question was asked about the fatality rate. I guess if you want to answer that on a local statistic.
Sure. Well, starting kind of at a high level, what we've mentioned in the past is 80+% of our COVID cases have been in population under 50, so younger adults down to pediatric, and we know that that population does very well. Often don't require hospitalization, require little to no intervention other than staying at home and resting and recovering. Now, once we get over the age of 60, mortality rate goes up pretty significantly across the state, across the nation. That holds true. Knox County Good Samaritan statistics are in line and the same as what we've seen across the nation. We're not seeing anything different locally than what we see really across the nation. And we know that over that age of 50, with other medical comorbidity conditions, as you mentioned, diabetes, heart or lung disease, that would make them more susceptible to the virus, increased mortality. Over the age of 65, by itself, we've seen increased mortality. That's why there's been such a emphasis on long-term care facilities and keeping the virus out of those facilities, ongoing testing of residents and staff. What we have seen, and I'll just to give specifics on the numbers, we've seen 21 as of when I looked at it over the weekend, 21 deaths related to Knox County that have been reported as COVID. We at Good Samaritan, because we're a regional referral center, we've seen north of 60 deaths across all of the communities that we have taken care of. Now, not to get too technical, but we in the healthcare field look at deaths in a expected versus unexpected as to, was this somebody that was likely to have a difficult time with the virus? Did their predisposition of comorbidities and health issues make them susceptible to the virus? All the treatments were provided, but in the end, their body couldn't fight off the virus. And what we have seen with that is that's been the case across the board. All of the available treatments across the country are provided here at Good Samaritan, but unfortunately, there are times where the individuals can't respond.
And interestingly, if we look at kind of what everybody considers now the first wave, we saw virtually no patients during that time. And when we were doing this, 5 months ago, 6 months ago or so, we talked about the fact that that was giving us time to learn from what was happening in the big population centers. And if we look at what the initial mortality rates were nationwide, and then the mortality rates that we're seeing now, it's lower now. And we know that's for a variety of reasons. One thing is we hope that it's the virulence of the virus is less than what it was before. We're certainly seeing that in the number of cases. There are lots more cases, but we actually have less deaths as a percentage of that than we were even 4 or 5 months ago. The other thing is, obviously, as Adam said, that we've learned a lot. We got to sit back and learn from what was happening in those population centers. And then during that time, drug availability changed, proning bed availability changed. That was our opportunity to ramp up our number of ventilators that were available, negative pressure rooms, so forth. All of that really gave us time to work on those things. And I know Dr. Stewart had commented a little while back when he had inquired as to how many negative pressure rooms we had available, assuming that it was the typical 3, 4, 5, 6, that we basically made the entire hospital negative pressure. And so all of those times have given us opportunity to get better at what everybody else was practicing on early in the spring. And so we've really seen that mortality rate go down. Now, as Adam said, the hardship of all this is we know that as age increases, the likelihood of having more problems and complications of it is greater. And we certainly see that reflected in our numbers when we compare those to surrounding counties. Counties that have a higher percentage of people that are over 65 have a higher mortality rate, and it's just statistically that they had more of that population that was at risk. So we're fortunate that we have been given that time to figure those types of things out, and our physicians have had the opportunity to talk to their colleagues who are experts on that in our population centers to help refine what we're doing. And then really the time that has passed during that has given us that opportunity to grow and learn and be the best at taking care of those patients.
Someone asked about schools, like how things are going there, if there's any potential for schools closing. I guess that must be a rumor.
Sure. And actually, I got that question last night as well, so I think that is out there. I mentioned that there's that weekly meeting that includes elected officials, law enforcement officials, health officials. School officials are also on that, and they give a report out each week as to how things are going. We've commented in the past, the schools have really done an excellent job if our entire community mirrored how well the schools have done, we wouldn't be sitting here talking about the state of things where we are. Their protocols have been very strong as far as identifying children with illness or faculty staying home, pivoting to virtual care or virtual learning when they need to versus on-site learning. As of right now, I'm not aware of any news of schools closing due to COVID outbreak or that type of thing. Obviously, we were just on a Thanksgiving break. In a few weeks, they'll be moving into a Christmas break into the new year. The Knox County schools have talked about coming back second semester, starting virtual for a few weeks to allow the Christmas and New Year's time to run its course. We often talk about the 2 to 14 day incubation period. So from New Year's, 14 days to make sure that the illness has been ran its course and identified, and it's not everybody coming back all at once. So that has been a discussion. But each of the schools is really handling it on a case-by-case basis. We've seen individual classes that have been sent home for virtual learning to isolate that class and the faculty that have been involved with that class versus shutting down an entire school. Their response has been really excellent.
And I think that's the exciting thing, and one of the advantages that we have as a community that is a bit smaller is the response can be more scaled to what it needs to be. And really the schools are kind of a microcosm of that they can respond very appropriately to whether there's a problem in a class, whether there's a problem in multiple classes or across the school or within one sports team. And I think they've done an excellent job of that. And so as of right now, of course, we are all trying to keep kids into in-person learning as long as is perfectly safe. And so far that's gone well. As Adam said, there have been a few classes that have been pulled out and a few sports teams that have been shut down for a brief period of time. But again, this is a daily, hourly sort of analysis and looking at how things go. And with the recent holiday that we've had, we're kind of holding our breath to see what's going to happen over the course of the next 1 to 2 weeks or so. So stay tuned as to what those numbers do. And then again, thankfully, we are able to respond more quickly and more appropriately rather than just a big mandate across the state or a big mandate across the county. Those schools can basically respond appropriately.
And I think that point you mentioned is really important. That the school, at the end of the day, their focus is they want to provide an on-site learning environment as long as that's the safest way to provide a learning environment. But they are all prepared, and certainly the end of last school year gave them the opportunity to ramp up their virtual capabilities. So all of the schools have the ability to pivot to that if that's the safest way to provide a learning environment.
And as of this morning, my children were certainly pulling for lots of snow and then about a 2-week period off. I told them this wasn't going to stick, so don't get a cart ahead of the horse right now.
Right.
Okay, someone asked about steroids being prescribed for this. Why are they prescribed 2 separate times? Just wonder what this does to help.
So it's a little bit of a complicated answer because the conditions that are associated with this definitely respond to steroids.
Right.
We have a number of patients, and there were a few that I cared for over the weekend that my colleagues called to get the monoclonal antibody infusion, and they were asking about, well, should we give steroids in addition to the monoclonal antibody? And it really depends upon the disease process. Sometimes when people have a history of emphysema, COPD, asthma, and lung problems that have been responsive to steroids in the past, there's some benefit to giving those steroids early on because we know that as you get into this illness, there's this inflammatory cascade that's going on, and we know that steroids work for that. The problem is that ideally the best case scenario on how we would hope to use what's happening with the monoclonal antibody is that patients that are at risk, as Adam was talking about, patients that we know have pre-existing disease problems and conditions, we want to identify them quickly with a point-of-care test. We want to then get them the antibody infusion as quickly as possible because we know that each of those interventions, the earlier that they're given, the less severe the illness is on the backside. Now, as Adam was talking about also, the other thing is for the majority of us that catch this illness, we don't need the monoclonal antibody infusion, and we don't need steroids, and we don't need antibiotics. We need time, and we need some Tylenol, and we need fluid hydration, and we get over it. So what we really want people to understand is testing when appropriate, and those rapid point-of-care tests in the population that is the sickest and the greatest is at risk are really, really important. Rapid point-of-care tests for those of us that are otherwise relatively healthy, don't change a lot of things, and it really doesn't change much in terms of what the treatment is. But we don't want folks to stay home and not go get tested who have those problems. And so we would certainly make a call out to individuals to get in touch with your primary care doctors, get to our convenient care clinic, get evaluated by people that can determine if you have those risk factors that would make it more likely to have an issue. Get tested, and then if you're a candidate for the monoclonal antibody, we are able to administer that very quickly. So the answer to it is a little more complicated than do we just give steroids to everybody or do we not. It really depends upon the disease process that is underlying and how that process either makes it better or worse for the coronavirus to cause issues.
Right.
Did someone ask if pulmonary fibrosis makes someone high risk?
Absolutely. So pulmonary fibrosis is basically a condition where whenever you're able to get air into your lungs and then try to transfer oxygen and carbon dioxide across the membrane of the lung, it's stiff, it's thick, and it doesn't work very well. So that's absolutely a condition that puts you at higher risk. It's a different condition than what COPD and emphysema and asthma would be, but nonetheless it is a chronic lung disease and something that we want to have early contact with you, be watching oxygen saturations, how bad the illness is, and ideally, if we can identify that illness within the first 5 to 7 days, try to get that monoclonal antibody administered as quickly as possible. And some of those patients also are at high risk not just because of the pulmonary fibrosis, but because of the medications that we give them to try to prevent the progression of the pulmonary fibrosis. So if you are on immunosuppressive type medications that try to keep your body from attacking its own lung tissue, it certainly puts you at higher risk. And so again, that's another factor that we consider when we're administering that medication.
And just putting in the plug, any of these high-risk conditions that we're speaking about those individuals should be thinking about their activity in the community and just decreasing that risk of transmission. So we know without a doubt the best treatment is quarantine, thoughtful decision making and where you're going and decreasing risk of transmission, because the best treatment is not putting yourself in a situation where you have the virus and we move down these other paths. And with vaccine on the horizon, we hope that we're starting to see that light at the end of the tunnel, but certainly high risk populations need to think about where they're interacting with the community right now.
Now, a question not on here but was brought up recently. So if someone is positive and then later down the road someone in their household is positive, what does that mean for the person that was positive earlier on? Do they have to quarantine? Or
I'm going to throw that one to Adam just because this is one of those questions that has no answer.
Right. So there's a couple of answers. So what we know is that there's been well-documented cases that somebody that tests positive and has has recovered from coronavirus has generated antibodies, and it's expected for a 90-day period that you would have those antibodies. It may be longer, but it hasn't been tested out much longer than that. So the discussion at point of being identified as a close contact, but you have recovered from coronavirus would be, if we're talking about adult age, it would be talking to your employer as far as their protocols for returning to work. If you develop any symptoms, it's an automatic. You are quarantined, you are isolating again. If you're completely asymptomatic, it is working with your employer. I know in talking to the schools that school age children that have tested positive, have recovered, returned to school, if they are deemed a contact again, they are not quarantined from school immediately, but are monitored for symptoms. So you would increase your tracking of your own symptoms, checking your fever, obviously checking any shortness of breath, cough, development of any new symptom. But ideally, somebody that is tested positive has recovered. If they are identified as a close contact again, would not automatically be quarantined for that 14-day close contact period because you're expected to have antibodies. But you have to talk to your employer. If you're school age, you have to talk to the school because their protocols are the trump card in looking at this as to what's safe to return, and certainly looking at symptoms. If you have symptoms, it's an automatic, you should be quarantined.
And that continues to be studied as we go month by month by month. There are people that are looking at that, and there are case studies of people who had this illness in the spring and then have acquired it again 4, 5, 6 months later. But roughly so far, we believe that 90-day window, you're relatively safe to not reacquire it and not be a transmission risk.
Okay, you answered one question about has anyone had it twice.
And just to add on to that, there are documented cases of reinfection. I believe a couple weeks ago I looked at, there were like 25 worldwide. What we have seen though is that there have been cases where somebody tested positive for COVID, symptoms flared back up, let's say 60 days later, got tested again and tested positive. That in all likelihood was not a reinfection.
Right.
That was the virus hung around, stress, whatever the case, your body let the virus kind of peak back up and you started having symptoms again. Same infection, not a reinfection. That's why that 90-day window, we don't advise for retesting. Anybody that tests positive should not be retested in 90 days unless there is a transfer all the way to hospital admission and there's some other illness going on. And if you test negative, you should not be retested for at least 96 hours. Those are important things for the community because we see folks coming out a lot. They're already positive, they want tested again, or they're negative and they want tested again 2 days later. If your symptoms worsen, talk to your provider, but retesting is not the answer in those scenarios.
Absolutely, because again, we're still trying to conserve what resources that we have, and although we have the rapid tests now that we're doing hundreds of those every week, it's important to realize that it doesn't make much sense to retest too soon after negative, and it absolutely makes no sense to test after you've been positive for 90 days. If employers or somebody are saying they need a negative test return, please contact your primary care doctor. We may need to get on the phone. We may need to write a note to say, this is not appropriate. It doesn't mean anything. If you are recovered, you are recovered, and a test really doesn't tell us anything about that.
So someone asked about the turnaround tests or turnaround time on testing. Some facilities have rapids returning in 15 minutes. Others are taking 5 to 7 days. So what does that look like right now?
So right now we have two types of tests in our ambulatory settings. We have the point of care test, which is the rapid antigen test, the 15 minutes that was mentioned, 15 to 20 minute turnaround time, and you have a result. That test is for symptomatic patients age 5 and up only. So asymptomatic, meaning that testing out of curiosity or you think you were a contact, that test will not be used. For that population or for somebody under the age of 5, the test is the gold standard, the nasopharyngeal test, and we're seeing that turnaround time at about 3 days. Now that continues to be a moving target. Sometimes it's bounced up to 5, sometimes we've been down to 2. That's the test that we send off that was asked about to a reference lab in Minnesota, to Mayo, that was asked about in the past. But those are the two types of tests: the rapid antigen test, 20-minute turnaround time for that population, and then a 2 to 3 day turnaround time for our send-off test.
And the send-off test, we've seen pretty reliably that 2 to 3 day period. And really, if you want to think about in terms of who that's ideal for, people who are required to have testing before surgery, if they go in for surgery and somebody needs a monitor before that, if work is requiring them to have routine testing done for whatever reason, that's okay as well. But I think the really important and key thing here is if you drive up to our community care clinic and you are symptomatic and you have risk factors, it's important that you get evaluated by a provider and get the point of care test, which comes back within 15 minutes, because you may be a candidate for that antibody infusion. Right. And so when people pull up to our community care clinic, they'll see that there's a sign there, a phone number to call. And when they call, they'll get a little bit of initial phone triage to say, why are you here today? How can we help you? And for people who are clearly on a mission, hey, I've got a surgery coming up next week. I was told I need to get a test. That's fine. Get the send-off test, which is 2 to 3 days or so. But if you are, let's say, 60 years old, have an history of COPD, emphysema, it's important that you realize that you want to be seen and you need to be seen by a provider and get that point of care test, because if it turns out that that point of care test comes back 15 minutes as positive, somebody has seen you, listened to you, and done a clinical evaluation, then you're a candidate to potentially get that antibody infusion. So that's kind of where that split and triage is happening in our organization and many of them. There's lots of point of care tests being done in other places, but the unfortunate thing is they get done and then people are sent home with a positive test and they don't know what to do with it. So being evaluated by a provider helps to plug you into the system to say, hey, are you a person that should receive treatment with the antibody infusion? Are you somebody that we can reassure or keep close contact with clinically and give some better instruction other than, hey, here's your test and go home?
Okay, this next question is regarding close contact. So maybe briefly explain who is a close contact and what they should do, and versus like a contact of a contact.
Sure. So a close contact is defined as being within 6-foot distance for a cumulative of 15 minutes while that person was potentially contagious. So when somebody tests positive for COVID, they look back 48 hours, and then there is a questioning and inquiry of who are you in contact with and what did that contact look like. So 6 feet or less, cumulative 15 minutes in that window of time, 48 hours prior to somebody developing symptoms or testing positive. It can be either one of those, would be deemed a close contact. Now that's where contact tracing comes in. That's really been centralized to being performed by the state, and will fully acknowledge, and it's been acknowledged by state representatives as well, that the resources for contact tracing are not enough for the number of positive cases that we're seeing. So this really puts the emphasis back on personal accountability to our community. If somebody is positive and tells you that they tested positive and you know you are a close contact, that should mean that you quarantine. You can reach out through our triage line to your primary care provider, ask about guidance for that, but that's that 14-day quarantine from time of exposure going forward, because up to those 14 days you could develop symptoms and become positive yourself. And certainly we know there's a pretty high risk with this virus that if you were in that 6-foot cumulative 15 minutes, that there's a high risk of transmission. Now, things that drive that down are wearing a mask. If everybody's masking, then you're going to go from high risk of transmission to low risk, and may not have to quarantine. There'll be a question and answer about that. So that's the definition of close contact and who would be at risk and have to quarantine. Now, if I tested positive and Dr. Stine was identified as a close contact, but Tiffany is over here asking the questions and she was a contact of Dr. Stine, she does not quarantine. You have to be a direct close contact of the individual that tested positive. If we started looking at multiple degrees of separation, everybody would just go quarantine. So there has to be a end to how that works. So it's only those individuals that were within 6-foot cumulative 15 minutes with the individual that tested positive, not with the individual that was deemed a close contact. Now, if they become symptomatic, that changes the game, and it goes from then that individual is kind of patient zero, if you will. It can be complex. My best piece of advice is, if you know somebody that's tested positive, you think you may be a contact, you have concerns about symptoms, call our triage line and let's walk you through that, or there are state resources through the ISDH website as well.
I can tell you that the most common scenario where people look back and go, oh, that was a mistake, is in their own homes, at social gatherings, and then for some people at sporting events. And it's because at workplace, because it's required, people are masked, they are already socially distanced by the nature of things that we are doing. At schools, same situation, socially distanced, everybody is masked universally. So it's very rare in those scenarios that we get a call and somebody goes, oh, okay, so yeah, I was a contact. But very commonly within individuals' households, very commonly out in social settings, very commonly when people go out to restaurants and retail and places like that, where they're not necessarily masking and their workplace or their school is not requiring masking, that's when they look back and go, oh, yes, I have had a contact. So realize that just as Adam said, the masking is really what is helping us to avoid those potentially unnecessary quarantine situations. And we're all really just one phone call away from a quarantine situation. If you can look back during that tracing, or when somebody calls you and says, well, we were masked and we were socially distant, then that 15-minute 6-foot rule, it's not an issue.
The largest place we see the breakdown of that from an adult employment standpoint is break rooms, eating areas, taking mask off to drink, eat, and doing that in a congregate setting. So everybody needs to be thoughtful about that. It's times that we're asking individuals to make decisions that are inconvenient, but out of that inconvenience is how we curb the trend that we're on. So being thoughtful about break rooms, eating, drinking settings, doing those in a distanced manner will keep you from getting that phone call where you're quarantined for 14 days.
Now, someone asked about if they've had COVID, have the antibodies, should they still be wearing a mask?
Yes.
Yes. Universally, yes.
Yeah. And even we've talked about the vaccine. Even with the vaccine, there is discussion that as we move through the waves, that let's say we move through healthcare and then we move on to the community, healthcare workers will still continue to wear the mask. We will until it reaches a point that there is herd immunity across the country from a vaccination standpoint, and then a mask mandate can be removed, because that risk is still there, and it's early in the data. And when we hear 90% effective, that's 90% effective. That means that there's 10% that it may not be effective and there may be risk. Despite having tested positive for COVID and recovering, mask mandate, social distance, all the measures stay in place.
And people, of course, will ask, well, when is that? And we don't know, but I'm telling everybody, plan on through the spring. Probably 6 to 12 months is what we are looking at. But again, it will really depend tremendously. As we hit the spring, we fully anticipate numbers will go down anyway. But as the vaccine gets rolled out, depending upon how many doses of the vaccine have been administered, what percentage of our population has had the vaccine, and then what we see with the local numbers and regional and nationwide numbers, that's really what's going to dictate that. So it's kind of a moving target. We're not evasive about it. We just really know that to establish that herd immunity, it takes a long time. So I'm telling everybody 6 to 12 months is probably what we're looking at in terms of when you get to ditch the masks. But really a crucial time period, I think, is going to be February, March, April, when we start to see spring coming around. If we see that natural decline in the illness anyway, I think that's going to be encouraging.
Okay, that's all we have today.
Okay. Well, thank you for joining us on Facebook Live. We will be back next Monday and hopefully have some new updates, and would love to be able to report that our numbers we're bending the curve and trending in the right direction, and coming out of the Thanksgiving holiday, would like to see that going down, so we don't have that surge then hitting into another surge. Dr. Stine, anything to add?
Thank you very much for joining us. We'll see you again in a week.